VT ablation is a technique that is getting more and more frequent, and is a technique associated with complications. One of them is embolism, although embolism is not very frequent, but now there are evidences that we have subclinical embolism more often than was previously suspected. It's unclear nowadays how can we prevent this, but the trend is to use more and more anticoagulation, and it's been proven that this is safe, despite that you may approach or tackle VT through different approaches, supraepicardially or endocardially. Phrenic nerve palsies is another thing that is becoming more and more, let's say, apparent, and then there are different techniques that you may use to try to prevent this complication. One is trying to first detect that you are in a risky area by pacing from your ablation catheter with 10 to 20 milliamps in order to see if you capture the phrenic nerve and in order to avoid RF application in that particular area. You may consider trying to interpose a balloon or fluid or air in between your ablation catheter and the phrenic nerve, and also you may consider to use cryo rather than RF in order to stop energy delivery before there is a permanent lesion. There are other things like distant capture, for example, pacing from the subclavian vein, that it may also help in order to early detect this complication. Erosion of the coronary arteries is another complication that is now more and more commonly seen, and this comes from direct puncture from your needle when you approach the heart from the epicardial aspect, and also by laceration when you manipulate your sheath without a catheter in front of it. So it's something that you have to be aware of and try to prevent sharp movements of your needle and having a sheath without a catheter in front. Yes, I think that nowadays we have two kind of complex arrhythmia ventriculars. That is what we have just discussed. At the atrial level is mostly atrial fibrillation, but also left atrial flutter. And these complications may become from local RF application or catheter manipulation, like embolism. Clinical embolism is nowadays very rarely encountered, but clinical embolism is not the case. We know that we have around 10%, 10 to 15% of clinical embolism. And presently we don't know how to avoid this, but probably in the future we'll see a more careful control of anticoagulation and of charring and bubble formation. Other complications that are uncommon but they are devastating when they occur are, for example, atrioesophageal fistula, and this is also something that is unclear how we can prevent this complication. You can titrate your energy delivery. You can use some different monitoring means in order to detect early or well in advance that you are injuring the esophagus. But probably also an important aspect is trying to prevent this complication by using measures after ablation like PPI, drugs, special diet, and especially avoiding agents like alcohol or other drugs that may injure the esophagus. In the future, I think that efficacy will be a driving force, but safety will be probably more important. And we should develop methods in order to avoid these complications that nowadays they are not common, but some of them can be devastating. So I think that improving our anticoagulation control of the procedure, preventing bubble formation, and preventing nearby or neighbor organ damage will be important. Nowadays, for example, we don't know what is the amount of RF that we have to apply, because there are different parameters that you may change, time, power, even the flow rate, and I think that I am foreseeing changes in this aspect. There are recent publications suggesting that you may use very high powers, but during short time, and this may prevent distant damage to other organs.